Everybody lives and everybody dies. Today, we're talking about death and dying.
So pour yourself a glass and settle in. This is Sweet Tea and Stethoscopes, spilling the tea on nursing in South Carolina, brought to you by the South Carolina Nurses Association.
As you guys can see, we've got a guest.
We have a guest today.
Love this.
Oh my goodness.
So,
Welcome.
welcome to Sweet Tea and Stethoscope.
Well, thank you. And might I say that the sweet tea is really good.
Thank you.
Oh, yes. I think we're all doing Arnold Palmer today.
We're on the Arnold today. Everybody has a little lemonade today.
Yes, yes.
So
Absolutely.
we're going to let you do your own introductions as a lady who doesn't need introduction. But we're going to let you do your own introductions today. So tell the people who you are.
Okay, well, first of all, I am Marisette Hassan. And I've never done this before, but what I will say is that my name in the middle of it spells the word rise.
Oh.
And so that's my thing, that no matter what the situation is, except I've never resurrected anyone from death, I will rise in the midst of the situation. So I'm a registered nurse. I have had an amazing career for 44 years. I am a University of South Carolina alum.
Go Gamecock.
Go Gamecocks. And I have had the pleasure of working in the care continuum with oncology patients at the bedside, moving into hospice, setting up community screening programs for cancer, getting into home health, hospice, and policy and advocacy. So I've had the full circle.
Love it.
And so thank you guys, Ryan and TK, for inviting me.
Thank you.
Of course.
And especially thank you for the tea.
Quite welcome.
Oh, we'll spill it.
I brewed it myself.
That girl's got some gifts. I can already tell.
So I want to talk a little bit. You've shared a little bit about your career, and I know Ryan's in the STICU, so you see a good bit of death, I'm sure, from time to time in the STICU because of the nature of the patients you get.
Very
And
much.
I have a hospice background as well. I've worked in hospice for years, but I just want to kind of, if we could, talk a little bit about some of our experiences and what got you here in the first place. Like, what happened? And maybe if you have, and this sounds crazy, but do you have a favorite death story?
I think my first experience with death was really looking at working on the cancer unit. I started as a new graduate and chose the cancer unit. I had an amazing shout out to Shirley Jeter at Baptist Medical Center back then. Um, she was an amazing charge nurse. And what I found was that not only, of course, did we do the medical things, give blood, give chemo, I liked all those sort of techie things that we had to do. But I love that what Shirley taught us was that we had to create an atmosphere in the room that was a comforting atmosphere. And so that meant that we took attention to look at the details. How is the bed? How are the pillows? Do we need to turn the pillows over because it just gets hot when your head is in that pillow like
Hello,
that?
perimenopause. I know that every
Oh
day of
my
my life.
gosh. But what I discovered was that, as people are dying, and even before they get to the transitional piece, they're worried. They have fears. There are things that's keeping them awake at night. And I know that people think that the nurses that work on the night shift do not do anything.
Not
Two hands up. Nurses do have things to do in the middle of the night.
lots of things.
We have less staff in the middle of the night. And patients really rely on us because they're not all sleeping.
Right.
And I found there were times when I had the opportunity to pray with people at the bedside that had an opportunity to hear what was on their heart and to support them and to encourage them and to create that environment. Their family members may or may not have been with them in the middle of the night. And so that was definitely a piece that I felt rewarded in. So transitioning to hospice to me wasn't scary.
Right.
It was like, okay. And then I learned, okay, what are those signs that I need to be looking at? There's a wonderful book written by Barbara Carnes on the phases of death and dying, and it's written in layman terms.
I've read it.
Absolutely one of those standard things that you give to every family. And it really takes away the fear from people because they begin to see what some of those things are. The breathing is going to change, their ability to eat is going to change, their limbs may get cool. They may even start talking about people who are already dead.
Right.
And of course, we're at the Halloween time, so talking to dead people, well, people who've already gone that are loved ones, they have this sort of sensory perception where it looks like they're looking up into the ceiling,
Mhm.
and they tell us that they're talking and we
Right.
think they're hallucinating, but who knows who it is that they see?
Right.
And I think the other thing that families appreciate is that even when their loved ones are in the last phase, they appreciate knowing when we tell them that hearing is the last sense to leave.
Correct.
And so the fact that I can encourage a family member to get close, to share what's on their heart, to be able to let them know, I'm still here, you're not alone, we love you. To hear music that's playing, creating that atmosphere of peace for the transition, it's amazing.
It's a gift.
Hmm.
Wouldn't you say it's really a gift to be a
Absolutely
part of
is.
it? We want to talk about death not being scary.
Hmm.
We
Yes.
really want to be. That's what this conversation is all about. It's taboo. And it's crazy because even in our world as nurses, it's still scary for a lot of people.
Hmm.
And I think that there is a real opportunity to help people see the beauty of it and see how it is that we can help. And I said to you guys earlier about like my favorite death story, and it sounds weird to say it's a favorite death story,
Hmm.
and it was tragic, it was sad, but it's one that stuck with me. And it was my grandmother's death. My grandmother's death is my favorite death story because it was one that I truly was a part of from start to finish. It was this lady's been in my life my entire life, like
Yes.
my entire life. But I was able to have hospice care. I was able to have support along the way. And even more so, I was able to hold her hand
Hmm.
when she took her last breath. So that may seem morbid to somebody that it's my favorite death story, but it's about that opportunity that I was given. And I really think that when we talk about this transition in life,
Hmm.
that the biggest word in this is opportunity. So, Marisette, what you think?
TK, it is. It absolutely is that we are privileged that people allow us to be with
Right,
them on
right.
their journey. That's what I felt
Hmm.
about hospice. And then, of course, when you tell people you work for hospice, like, oh, there's this expression on their
So
faces like,
hard.
how
Oh my
could you
goodness,
do
yeah.
it?
The public perception of what hospice is.
Right.
I mean, the simplest of terms, right? I mean, we would say it's the last 6 months
Hmm.
of a transition of life to death. I know my experience with hospice is in the acute setting.
Hmm.
It's sudden. Most of my patients aren't communicating. I see more compassionate extubations
Mhm.
Hmm.
because you certainly don't tell a family member this is a terminal extubation.
Right.
It's no, we are transitioning to comfort measures.
Hmm.
My goal is comfort. And even that public perception is dangerous depending on if you don't fully assess the family's perception of what the care you're about to transition to. The patient gets discharged from the unit and readmitted under a hospice care set. A lot of comfort care measures get added,
Hmm.
Foley's, oral care, kind of very specific kind of secretion management order sets come in. However, there with that comes this new set of medications.
Right.
And there is a very predominant perception that those medications are facilitating death.
Correct.
Right. This is the myth that's out there. They're going to give you that morphine,
That
and
morphine.
that morphine is going to kill them.
Right.
So you don't want to get on
Don't get
hospice
on
because the minute
morphine.
you get on hospice,
You're right.
they're going to give you that morphine.
Hmm.
Which is
And
so not
so
true.
that whole education around how we are, it's a comfort measure. So your loved one is not struggling to
Right.
breathe. Your loved one is not struggling with pain.
And you're not struggling to hear,
Yes.
to listen to it.
Hmm.
Because we all know when you get to, close to end of life, that for a family member, that sound alone of
Yes.
listening to that loved one breathe and they're struggling to breathe, when they're having that air hunger
Hmm.
can be traumatic.
Absolutely.
So to be able to offer them, here's something that helps. Before we dive too deep, I want you to talk a little bit about the difference between palliative care and hospice
Okay.
because we kind of we did a little time with hospice, but let's
Mhm.
talk a little bit about the difference of the.
Let's do it. You see, palliative care right now is its own care continuum. So when you think about the serious illness care continuum, I always like to think of it like this. You have patients who are at the early part of their illness, right? I'm sorry, I talk with my hands, so.
I do too, all the time, all the time.
And so, say you've got someone who's got congestive heart failure and
Mhm.
they're early stage, they're probably stage 1 or stage 2, but things progress and they get to about stage 3. Well, at that point, right now, there's some work being done through the American Heart Association where the clinicians came together and came up with a pathway of when is the right time to refer someone to palliative care. So we're looking at palliative care further upstream
Right.
as opposed to downstream at the end. The other distinguishing difference is that with palliative care, you don't have to stop curative treatment.
Right.
Not at
So
all.
palliative care is enhancing quality support, supportive care, while the patient is still ongoing curative treatment. I'm going to use an oncology or a cancer diagnosis as I think it's easier for people to understand. So often when you're getting treatment for cancer, you're getting chemo, you're getting radiation, you've got a sort of a cadence of when you're getting that treatment. Radiation oncology may be given to sort of shrink the tumor mass, and then you're still going to get chemotherapy. And in that midst of that, you could experience some uncontrolled symptoms. You could need some support in terms of handling pain, in terms of talking with a social worker about some resources that you need support with, and you're still getting that treatment. The mindset typically, and we're always having to educate our clinicians, particularly our physicians as well, but you don't have to stop treatment to get that additional support.
Mhm.
We're going to continue to allow you to have chemo, to have your radiation treatment without stopping it and saying it's no longer working.
Right.
You're going to be able to get an additional layer of support during this time that you are getting this treatment. And during getting that additional layer of support, could be that you're going to have someone who comes to your home, like a nurse practitioner, who is able to walk with you through your medications, see what's working and is not working because they have that skill set. And you say, you know what, I have a poor appetite. I'm not really able to keep things down right now, even though I've got the medication. So that person is going to use their skill set to assess, okay, what are you currently taking? What do we need to change? And then also communicate with the oncologist to let them know what's happening in the home. And so I think that's the piece. When we get to hospice, we're saying we are no longer pursuing curative treatment.
Correct.
Mhm.
So that means that no more chemotherapy, no more radiation. The oncologist may say we've gotten to the point where what we've been trying is no longer being effective. And so we believe this is the time where we want to transition you to comfort care. Now, comfort care does not mean that you're not going to receive medications to take care of pain, to take care of nausea, to take care of anxiety. We are still going to provide you what you need. We're not going to just let you hang out to dry. But what it does mean is now you're going to get additional support to help you and your loved one at home during the last 6 months of life. Now, I often tell patients and family members and community that we don't have a crystal ball. Medicare has given us the definition for hospice,
Right.
that the prognosis is 6 months or less if the disease runs its normal course.
Right.
The physician is using his best judgment based on the patient's medical trajectory as to when is the right time. They're looking at things like, have they had weight loss, significant weight loss? Have they had several exacerbations of their care? Have they had hospitalizations? Have they had infections? Those kinds of things to determine whether this is the right time. One of the things we'll find is that also we will ask the clinician the surprise question. Would you be surprised if your patient were to die in the next 6 months? And if the physician says, I would not be surprised, it may indicate that this is the right
It's the right
time
time, right?
to put them on hospice. Now, some people die way less than 6 months because the referral in our mind came late.
Mm-hmm.
But a lot of times, depending upon the family and the culture of the family, people don't want to give up.
Right.
They don't want to feel like, from a faith perspective, that they didn't believe God. That's something that
Mhm.
comes up
Totally
sometimes when
understandable.
you
Yeah.
talking
And I'm
about
sure
that.
you've seen a
And
lot of
and
that.
I've had family deny that comfort, those comfort measures, because they don't want to get in the way of God's will.
Mm-hmm.
Because that
So
morphine.
so the other side of it. So you're seeing when you said they don't want to get in the way of God's will, if they
Mhm.
see someone who is transitioning, they don't want to do
Mhm.
that.
Correct. They'll
Okay.
go forward with the compassionate extubation
Uh-huh.
without
Mm-hmm.
the support, the comfort
So
support.
see, and some people don't realize that there's that difference in that.
Right. And other people will say, well, it's going to be like I don't have faith. And my response back to them, and I said, God is big. He is not intimidated with hospice. So get the care to support you and your loved one at home. And when God is ready for that miracle to happen that you are expecting or that you desire, He can still do it. He's not put off by the fact that you've chosen hospice.
Right.
And I've seen families just see like there's a sigh of relief that they are not, you know, sort of laying down on their faith and in this moment that
Right.
they're, it helps them not have a faith crisis,
Right.
that this is a part of the journey.
Right.
But you're on what you're saying, Ryan, is that, there again they're saying, hey, we're going to let God do what it is that He
Mhm.
desires to do. It's the same thing when we're talking with people about an advance directive or
Mhm.
what do they want it in. That's a whole nother conversation
Mhm.
about
Mhm.
do everything. Well, what is
What does that
everything?
mean? What does
Right.
everything mean?
And what does that look like?
Right.
And
Because people
Exactly.
don't know what that looks like.
right.
Hmm.
And another thing too, when we think about, a hospice diagnosis for a patient, I remember having patients who met all the criteria for hospice and decided to become a patient
Hmm.
and live longer than 6 months.
Absolutely.
Because sometimes I had a patient who was on hospice for 3 years,
Whoa.
Hmm.
which
Don't
is
say that too
which is
loud.
no,
Because
listen,
we don't want
we
Medicare.
don't want, of course, and but that's an abnormal
It
situation.
is. It's
But
not
when I
normal.
tell you this person was ill the entire time,
Hmm.
and every time I would go in and see this patient, I would think, I'm not going to see them next week.
Hmm.
I'm not going to see them next week. And this patient wound up, holding on for a very long time. So
But the documentation,
has to support it. And we have to
so
readmit
you
them.
had the
You have to
documentation
readmit,
to
and
support.
the option to come out of hospice
Yeah.
care is
Yes.
is
You can
there.
come
You
out.
can
You
come
can
out and
say,
you can come back
and you can
on.
come back.
You absolutely have options. And I feel that's a part of our role,
Hmm.
is to really empower patients and families to know that this is your journey and you can decide what it is that you want. We want to encourage you that we're part of your village.
Right.
We
Oh,
don't
I
want
love
you
that.
to have to do it in isolation, to
Right.
do it alone.
Right.
We're a part of your journey. But you are, a friend of mine said this morning on a call we were on, you're the driver of the bus.
Mm.
And so we're coming alongside you. We're going to encourage you. We've got the things to support you on the journey, but you're the person that's in charge.
That's right. And when we always talk about patient centered care.
Right.
That's a patient centered care moment when that patient, if you are, lucid enough and you have the opportunity to really have ownership and partnership in your care, I think that's one of the greatest gifts we can give someone. I would love to just talk a little bit about the stages of death, and so that if there's a family member maybe watching this,
Mm.
that they kind of understand what's
Hmm.
happening. And we can do maybe a brief synopsis of that.
Okay. So, I think in the beginning, when we talk about the early phases, we begin to see that there are more changes with the patient's medical condition.
Hmm.
Those are the early changes where the medication isn't working like it was before.
Right.
You used to be able to, you had CHF, congestive heart failure, but now, and you didn't have to have oxygen, but now you're on oxygen.
Hmm.
Now we're finding that it's difficult for you to ambulate from the bedroom to the family room or
Right.
from the family room to the front door. So we're beginning to see that there are some physical changes.
Mhm.
When it relates to people who have dementia, which dementia is really tough to think about when you're in those final stages.
Right.
When you think about dementia, those early stages are there's some memory loss, there's some, you're still eating well, you're still ambulating. You don't remember names of some of the family members, but they're still a little bit recognizable to
I
you.
remember some of them now.
But as we get more advanced, we realize, okay, now they're not eating as much. They were eating a half of their portion on their plate, and now they're only doing a fourth.
Right. Right.
Now we're seeing their faces more sunken.
Mhm.
Now we're beginning to see that the arm circumference, is smaller.
Mhm.
And so we begin to see with those patients, now we're seeing some incontinence.
Mhm.
Now we're seeing that now they're having more, they may be having a UTI or they may be having pneumonia. Their skin integrity is altered.
Yep.
And so now we're moving through where now this person is not as robust and vibrant as they were before. And then we get to the stage where this person's sleeping more
Right.
than they are awake.
Right.
We find, and I'm thinking more from the home perspective. So they're
No, this is great.
they're
This is
they're
great.
Yeah.
sleeping more than they were before. So there's more hours sleeping. We know sometimes with dementia patients they get their days and nights mixed up,
Mhm.
but there are more hours that they're asleep than they are awake.
Right.
We find out now they're needing greater assistance to ambulate and may get to the point where they're in the bed and not able to get up. And then we began to see, okay, now, and I always tell families because, we're a culture that loves to feed people.
Goodness.
We
Yeah.
absolutely,
Mhm.
we're in the South, we absolutely feel that food is medicine.
We like our tea sweet and our chicken fried. That's what we do here.
There's that. I have substituted for an air fryer now, but I do put a little
Air
olive
fryer.
oil on there so I can get the little crispy. Oh, I digress. I digress.
No,
Oh, this
listen,
this is what we do. So welcome
like-
to Sweet Tea. This is what we do. We got to
Listen.
sometimes go down the rabbit hole.
air fryers. I have a confession. I went TikTok famous during the pandemic with my air fryer. I got millions of views me cooking in my air fryer.
Are you serious?
Yes, my love with my air fryer is
Okay, so now I
beyond.
got to go back to TikTok
Yeah.
and go find out what's
Find
on
that
it.
account from
Are you so
2000,
serious?
2021.
What your name is on TikTok?
It's the same handle as Instagram. That's all I'll say.
Oh, okay.
Y'all go find it. Go find it.
Millions
Go
of
find it.
views. I made a couple $100. It's fine.
I love
Oh
it.
my God,
Right.
look at that.
Cooking food.
And so,
There was some chaos involved.
yeah, but that's the part that's tough for families.
Yeah, it is. It is.
Part, yeah.
It is.
Their loved ones aren't able to eat. And so having to tell them, listen, we don't want them to aspirate.
Correct.
So when they're not swallowing, if you're doing this to their neck and they're not swallowing, it's not safe for
Not
you to
safe.
give them food. They're pocketing food in their cheeks,
Mhm.
their whole, it's not safe. And so we see that this is a physical thing that's going on. So the difficulty swallowing,
Mhm.
the pauses in between breaths.
Right.
So, we have
Yeah,
that chain
moments,
stoke
yeah.
breathing. And so it looks like they've stopped breathing.
Right.
And they take a breath and you're like, are they going to breathe again? Or are
And
they?
then
Yes.
it's that.
Yes.
Yeah. So
Yes.
yeah.
Or this rattle that we hear.
Mhm.
And so that's when we use, the patches, or atropine drops to dry up
Melamine and
those secretions.
Secretions.
And so I think those are those pieces, but we'll see longer pauses. And then the extremities are no longer
They're
warm.
cold. Yeah.
They're beginning to be cold, right? And so I think those are the kinds of things. But then I think the semi-comatose state where they're not really communicating with you anymore.
Right.
I often would tell my chaplains and social workers that you're documenting, everybody documents decline, not just the nurse.
Right.
And so, whereas the patient early used to pray with you when you prayed, or they led the prayer, or they sang a hymn, now they're not able to do that anymore.
Right.
Now they're looking in the corner and they're talking about the people that used to be living,
Mhm.
right? And they're talking about dreams they're having, about, the loved ones that are there, inviting them to come with them,
Uh-huh.
you know. So some of that happens. But the sense of hearing, as we said before, is always there. But then there is this quietness that happens,
Yes.
and you're not able to feed them any longer.
Mhm.
You know, they are preparing to make that transition.
Right.
And so, you know, the thing that is, my mom was on quasi palliative care back in the day.
Uh-huh.
And as a nurse, it was so tough for me to honor what she wanted because I wanted to hold on to her. And I think that's the human side of us
Of course.
as healthcare professionals when our loved ones are transitioning. And she was desperately telling me, I'm ready to go.
Right.
I want to go home. And home was, I want to go back to Roundo, South Carolina. Shout out to my family in Roundo.
Roundo.
Y'all know where Roundo is?
No.
No idea.
Okay, Roundo, South Carolina is 8 miles outside of Walterboro, South
Okay.
Carolina,
Okay.
Yes.
Okay.
Okay.
That's a
Go.
good framework. I know where Walterboro
off
is.
of I-95.
Right.
And so, a little
Colleton
bit,
County. Yes.
Colleton County, yes,
Got it.
where my grandmother and my aunt were going to take care of her, and I took time
Oh.
off. But she had metastatic colon cancer that was everywhere. We couldn't even
Mm.
do a colostomy. And so she was trying to prepare me
Mm-hmm.
for what the end was going to look like.
Mm-hmm.
And so for her, dying meant being in a comfortable place with the people around her who loved her,
Mm-hmm.
much like your grandmother.
Yeah.
So we did that. And I knew when I left her, I took off a month of work,
Mhm.
but I saw the signs. And I knew when I left her that last Sunday to come back to Columbia, I was there for about 4 weeks, that I might not see her again.
Right.
And yet I felt the tug that I needed to get back to work.
Mm-hmm.
And then I get the call from my younger sisters that afternoon. Mom is, you know, stuff's happening, and she's not talking to us, and she's got all these secretions, and you know, they used other words,
Right.
obviously, as little girls. And I knew then she was gone.
Mm-hmm.
But she was where she wanted to be
Mm-hmm.
with the people that were around her.
And how, that's so important.
Mm-hmm.
That's so important to be around people, to be in a place. And that's what hospice allows people to do.
Mhm. And listen, her doctor didn't initiate this conversation with her. She initiated it. She was the one to say what it was that she wanted.
Love that.
And the team that I was a part of, I had just transferred to the hospice team.
Mm-hmm.
And so, you know, we had scriptures on the wall, we had worship music playing. I mean, we
Mm-hmm.
were full on. And
Oh,
we
yeah.
had fought cancer for 2 years and she went into remission. So, you know, we were just all full on until she said, hey, this is what I need you to do.
Mm-hmm.
But the team, because back then there was no hospice in Roundo, Colleton County, there was no
Mm-hmm.
hospice back then. But the team traveled.
Wow.
Mark Brett Holt, the chaplain at that time, traveled from Columbia to Roundo
Wow.
to support not only me, but he had developed this relationship with my mom.
Mm-hmm.
And although we had a pastor at home, there was something about what Mark brought to my family that was different from what my pastor was going to bring.
Mm-hmm.
Was
Absolutely.
also going to be struggling because my mom was that, she was that chick that was at church all the time singing on the choir,
Mm-hmm.
ushering,
Mm-hmm.
you know, I mean, with the white uniform
Oh,
on
yeah.
and giving directions. She was that.
She the one who did I got two in the front. I
She
got
was
two in the
that
back.
girl.
You know, that's the old
Popping
school
those-
church. Yeah, I got two seats in the front. I got two in the back.
And I'm gonna need you to slide over.
Slide over, and
Oh,
and then they would come
goodness.
to you when I was a kid. They would come to you like this when you had gum in your mouth in the church, and they were holding a little cup just like that.
What you not gonna do?
It's being here chewing this gum at church.
Stop it.
I'm so serious. Yeah, this little cup, just like that little cup pan, and you knew right
My
then. Just
goodness.
go
And you
ahead.
bet not have your dress too short.
No.
They're gonna bring something over your
They're
lap.
gonna give you a lap scarf,
Oh,
a lap
my
scarf. But
goodness.
what you said, that makes so much
I'm
sense.
gonna adjust this real quick.
Okay.
When we talk about our faith leaders,
Mhm.
most of the time they have a relationship with that person. And as much as they funeralize people and all those other things, it is totally different. Like the education that a hospice chaplain receives,
Yes.
whether they are of the same faith or not. I've
That's
had
right.
patients who were of all types of faiths,
Mhm.
and whoever that hospice chaplain is
Mhm.
that's on call or that's in support at that time may be of a total different faith, but they come in,
Yeah.
man, and it's like
Yes.
they know where to pivot.
They're all things to all people.
Right.
They understand
Mhm.
how to universally provide spiritual care. And what we see as spiritual care is the religious task of what we think spiritual care is. So we see spiritual care as the communion,
Mhm.
not knocking communion,
Right.
reading of scripture and prayer. But sometimes there are some loose ends that people have. There's some closure. Oh,
That's the word.
about to go there.
That's the word.
Sometimes there's some closure that's needed where we are going to need to talk about some unforgiveness.
Mhm.
We need to talk about some bitterness or some pain that we've had.
Mhm.
We have an issue. We had a patient who had had his common law wife for several years, and it was the chaplain.
I was looking at Ryan's face. He was just like, I
Listen.
know it.
And,
Because you see a lot of that, I'm
Oh
sure.
my goodness.
and the chaplain, he said, I want to marry her before I die.
Wow.
And so our chaplain, Maurice Weber,
Hmm.
for our hospice, he performed the ceremony.
Wow.
And he did not live 2 weeks after that ceremony.
Wow.
But that was look at that gift. That's a gift.
Mm-hmm.
One for her, that as she passed, as he passed, excuse me, that was her husband.
Mhm.
They had been together all this time. He probably was always her husband in her mind.
Right, right.
But
And as far as the law is considered, she
right,
was his wife.
that's right.
Right. But in his heart, he knew
He
that was
knew
a
it was
piece
right,
that
Wow.
was unraveled that needed to be tied with a bow.
right,
Mm-hmm.
right.
Mm-hmm.
Because it put a
Yeah.
stamp on it. It also meant that in a way that he was preparing to cover and protect her even when he was no longer here.
Yes.
Yeah.
I
Yes.
think
It's it's some things that happen with death and dying as people are preparing that sometimes the pastor doesn't know all the stuff.
right.
But there's something about that atmosphere that the team provides
Mm-hmm.
that allows that when you connect appropriately, there's this authenticity and openness that happens where people can begin to share. And then they can get healing.
Hmm.
We
Mm-hmm.
always look at healing as healing for the body, but there is the healing of the soul. There is the
Mm.
healing of emotions.
Right.
And so we're privileged to be in a position to be able to facilitate what people need in that moment through the dying process.
I
Right.
love that. What you think?
What's rolling in my head right now is just the continuation of the assessment of the not only just the patient desires, but also the family and cultural, religious needs in those moments.
Mhm.
Um, again, the transitions are usually very quick.
Right.
Hmm.
When I say I'm not looking at these prolonged transitions of care and guiding the family through this very progressive kind of transition, right? Um, so it's a lot of quickly assessing
Hmm.
Hmm.
what those families need, how they can best be comfortable in that situation, and sometimes that means allowing 20 plus family members to gather around and
Right.
to be there
Right.
in that moment. And is that taxing on me as the nurse? Yes. Is that
100.
taxing for the unit secretary, the security who's managing the door? Yes. Um, but as a team, working with hospice, working with the palliative teams, and working with the cultural translators,
Right.
I've had to work on that transition
So
with the
important.
language that we don't even have access to in the hospital. We were using an embassy to translate, which is
Wow.
Wow.
borderline almost inappropriate because medical information
Correct.
needs to go
Correct.
through.
But
Right.
But when there is one translator
Mhm.
in the entire US for
Mhm.
this language that is
wow.
appropriate, we had to
Do
use.
you remember what it was?
I don't. It was
Okay.
such a unique dialect in the Pacific Island.
Okay.
And
Wow.
it was so for them. The embassy helped us. Like,
But
hey, this is.
kudos for providing that
Right.
Oh, it was.
because that brought comfort.
Right.
It did. Oh, of course. Oh, and it was
Much comfort.
And probably for you all too, right? Because you could understand.
what they, how they were acting, how they, what they were requesting,
Right.
right? We were fortunate to have some English speakers in the auxiliary, like the outskirts of the family, but the core family unit was not.
And the thing that I love about what you're saying about this is we have to admit and we have to be willing to have cultural humility. To
Mhm.
know that our language is not everything,
Right.
that our culture is not everything, that where families live and breathe, who they are as a family and who they are as their culture is so, so important. And it's okay for us to ask, what is it that you need? To say, I don't understand. What can we do that's going to make you more comfortable?
Right.
What is it that you normally happens? I'll never forget the first time I cared for a Jewish patient.
Mhm.
And I did not realize that the death ritual was the way it was, that they have to bury within 24 hours. I said, oh my God, they're burying so quickly because my culture was so different from theirs.
Mhm.
But when I began to understand what was important to them, it wasn't a problem. I mean, we understood. And I had to admit, this is something I don't know. And they were willing to share with me why this was
So
their
you got an education as well in
Of
that
course.
moment.
I
And
did.
Well, that self-assessment is just as much a part of the family assessment,
exactly, because you
and
got to know how you feel in that moment.
address your bias and address how you, maybe that you're neglecting a part of their care because of something you're thinking or
Right.
perceiving or assuming.
I had that situation happen, kind of what you were talking about. So my uncle passed last year in my home. He passed in September. So he was Muslim.
Okay.
I have a Christian background.
Yes.
So, of course, he's my uncle. He's been telling us over the years about certain things that they do that's expected. So, you were talking about that 24 hours. Um, they have 3 sunsets. When he transitioned, and it was relatively quick. Like he had been declining, but he was eating and everything up until the morning that he passed. So we're like, okay, we don't know. We're not Muslim. We don't know Islamic culture, and we want to respect it.
Yes.
So we went to the only mosque that we knew of in the Columbia area
Right.
and said, hey, we need help. He went to the funeral home that night. By the next morning, the brothers from
They came.
they came and got him. They did the ritual.
Wow.
They actually came and got his body. They didn't do it at the funeral home. They came and
Wow.
got him and took him to the mosque.
They had a way to transport him.
They did. They have their own hearse.
Wow.
Wow.
To facilitate that for
The mosque does for their, yes, they have their own hearse. And they came, they got him, they did the bathing of the body, all the things, and they did the wrapping that's required. They do 3 sheets, and there's a way that those sheets have to be tied. But they did that, and they allowed us non-Muslims to come to the mosque, which was a kindness.
Yes.
But they allowed us to come.
Because you guys were caring for him.
Right, right.
wow.
They allowed us to come into the actual space. And they had prayer that was going on, and they allowed us to spend some time with him, with his body. But literally, it was his face because the ritual had already been done and it was already wrapped. And the way that it's wrapped is really important, something I didn't know. So he was buried within 48 hours. He was buried here in South Carolina because he had to be in the ground within that 3 sunsets.
Sunsets.
So I didn't even know that there was a Muslim cemetery here in Columbia.
Where is it?
It's actually a more Columbia Blythewood area. It's off of Fairfield Road.
Wow.
It's on
Okay.
Dubard Boyle Road,
Oh, yeah.
going down Fairfield Road.
Yeah.
And there's an actual Muslim cemetery. It has when you pull up to it, it has listings of things that you can and can't do. Like we go to a funeral, and I'm saying we because I think Ryan probably more reserved in that. But sometimes you go to a funeral of people of color, and folks tend to do the most.
Well,
We gonna do all the things,
yeah,
right?
we do all
But
the
part of that is cultural.
it
But
is culture.
there's a sign that says you can't do those things. You can't, if you're going to cry aloud, You can't be on the premise to do that.
Mhm.
If you want to pray for that individual, you pray silently. Um,
Because
there's no service.
right, we have a service at the burial, and
Uh-huh.
so with the service at the burial for people of color who have a Christian faith, there is the ashes to ashes, there
Dust to
is
dust.
the committing of the
Mhm.
body, there is the prayer to close out
Mhm.
everything. There is the speaking to the family one last time as they're gathered,
Right.
and
Mhm.
so there are those pieces that
Right.
that
And
are
we didn't
happening.
get that.
Mhm.
What we got was we got there, they brought his body. They had one of the brothers said a very short prayer and then said a few things in English, but it was just a very simple prayer.
Mhm.
Um, their bodies have to be pointed to the east when they die, just as if they were praying.
Mhm.
So they are shrouded and put into the grave. There's no cast in the grave. There's no, normally we have that
Yes, there's a
the
inner
lining, the inner lining.
inner lining, and
That's
then the
not done.
casket is placed
That's
inside the
not
inner
done.
lining.
It is literally a dig in the ground, hole in the ground, and the body is placed facing the east.
Mhm.
They took pieces of wood that were all the same size, slats of wood, put the body on its side. It's not flat, it's on the corner on its side, facing the east,
Wow.
as if the person was praying.
Wow.
And then the slats are laid across to make sure that the person doesn't tip over.
Mhm.
And then it is filled back up.
Do they allow embalming?
No,
That's the other reason why I have
no
to come
embalming.
within
Yep,
72 hours.
no embalming. So, but when we think about nurses, these are things that I've been a nurse over a decade and I never knew that.
Right.
So,
We need the training, and I think that's the piece of that in the season that we're in now.
yeah,
That cultural competency relates to spiritual competency as well, and our understanding of different rituals,
Mhm.
of cultural pieces that happen within families.
Right.
Those are things that, if I'm in a different culture, it's completely different from how things are. I have my sister-in-law is German, and how she responds at the end of life is completely different. And so, there are just those pieces. So, I
And
mean, it,
yeah, and where is hospice in that loss and mourning process with
Right.
cultural competencies? You see those cultural differences immediately, whether
Right.
there is the calling out,
Mhm.
the out loud praying,
Mhm.
that is very public and very emotionally
Mhm.
driven.
Right.
And you
We're
do
trying
see
to
the
prepare people for that. So
yeah.
we prepare our staff by doing trainings around what are some of the mourning and grieving rituals,
Mhm.
So there's that piece of that. And it's the kind of thing that it's not a one and done.
Never.
Every time there's a family that comes that has a different background or a different ethnicity and culture, we have to revisit because there's so many different kinds. So then we have to look for those cultural brokers in community, much
Mhm.
like what you did
Right.
with and spiritual brokers like
Right.
what they did. And we bring them in to help to educate our staff so they can be open about what they may see. Um, it was very interesting to my colleagues. In the time when I came into hospice, there were very few nurses of color that were working in hospice.
Mhm.
So you're talking 38 years ago. So I'm going in with my happy brown self, going in to Caucasian homes.
Mhm.
And, to their credit, the authentic connection didn't cause there to be a backup for them with me coming in to serve them.
Mhm.
So that was really good.
That's
We were
beautiful.
able to connect on. You have to, in those first moments when you meet people, you have to find something personal that you can connect with them about and not just jump straight to the business.
Mhm.
There has to be that piece of building. And Ryan and I were talking about this early about that interpersonal piece.
Build trust.
Yeah.
But I think it's those pieces where you have to get to understand. And for me, that was the best that I could do was that's how I was able to succeed because I was in a world where most of the staff didn't look like me and the patients I was serving. Why is it that I loved hospice? I loved this process because of how I began my career on the
Mhm.
oncology floor.
Mhm.
So I didn't see it as a deterrent. I just saw it as a way that I was privileged to be with people and the love that folks have for you
Mhm.
when you are with them and you're responsive and you keep your word.
Mm. Yeah.
See, when we say that we're going to show up,
Show up.
when they call us in the middle of the night
Yep.
at 2 o'clock, because people don't die at convenient times all the time.
Ever.
I mean, it's 2 a.m.
Change a shift.
And you know what I remember? I remember having to get up in the middle of the night.
Mm.
And they're telling me, when you get down this road, and I'm in Lexington County, when you get down this road, you're going to make a left turn at the white fence. And it's so pitch black, you can't see the white fence. There was no GPS, happening during then. But you get there and you are comforting them, and you showed up because you told them they could
Mm.
depend on you.
That's right.
Right.
That's right.
And so you show up, you support them, you handle all the pieces. So hospice is required under Medicare guidelines
Mhm.
to provide bereavement care to their patients' caregivers once the person has died for up to 12 months. Really, the regulations say 13 months.
13.
And so, but here's the thing, the hospice team, when they first get the patient, they're doing an anticipatory grief assessment on that caregiver. And then when the patient dies, they do another assessment, the bereavement risk assessment.
Yep.
And they begin to look at those things, and they have to customize a bereavement plan of care. Now, that bereavement plan of care is going to be based on the risk assessment. So, with this, if you're at this number and it tells you some of the indicators, this person needs to have an in-home visit.
Right.
This person needs to be referred to a support group. This person is low on the risk, and so because they're low, we can just send them educational materials at a certain cadence, throughout the 13 months. We can use the team to do follow-up phone calls. We can use volunteers, and if we're a large enough hospice where we've got some sort of support group, we can do that.
Right.
Lots of hospices will do memorial services with those surviving relatives to remember the patient. It also helps the staff as well. High risk means that this is a person who has no
No support.
community.
Mm-hmm.
They've got no support. High risk may mean this is a person whose finances are going to be in a bad way
Right.
because their loved one,
Was
the
the
financial
breadwinner.
resources, that person was the breadwinner.
Mhm.
Mm-hmm.
High risk may mean that this person is frail and elderly themselves.
Right.
And how often we've seen, Ryan, where someone who's been married for 60 years and their spouse dies, they don't live too much longer
Right.
after them.
Right.
So there's this piece of us that understands that, okay, we need to keep eyes on this person because of the longevity of the time that they've had with their loved one. Most recently in Camden, there is an elderly gentleman who his wife died about 8 to 10 months ago, and they had been married 65 years.
Wow.
And he goes to her graveside every day, to the point now where the residents of sort of that Camden Elgin area, when they see him, they now have a campaign to blow the horn at him to let him know he's not alone. But he is so devoted to go sit by her. It's off of the church is there and the graveside is there, but that relationship was so key. You think about 65 years with someone who's your partner,
Mm-hmm.
Hey.
and the things that you've dealt with. He's got children, grandchildren, etc. But that's a part of his daily ritual now. He's someone that I would say, even, I don't know if they had hospice or not, but that eyes need to be on him
Right.
Mm-hmm.
because of the process he's going through. So those are those bereavement care resources. Now, when we back up and talk about the legal pieces, this is a piece that needs to start before someone is even on hospice.
Mm-hmm.
Really, like now.
Now, you're healthy, you and I,
Mhm.
we should be having conversations with our loved ones
Right.
to set up our advance directive, our healthcare power of attorney.
Mm.
Who is it that we want to speak for us in the event that we can no longer speak for ourselves?
Right.
And I often tell, because I'm doing a lot of these talks now, shout out if you want me to come to your church. I do it at the benefits of advanced
Let
care
the church
planning.
say amen.
Amazing.
And I often tell folks, sometimes the person who should be the healthcare agent may not be the person you think should be the healthcare agent.
That's the truth. That is the truth, because sometimes we think that it's immediately the next of kin, or it's the child, and those are not the people who are equipped
Mm-hmm.
They may not be equipped.
in that moment.
Mhm.
Not that they're not educated enough or
Mhm.
intelligent enough, but just sometimes the emotional
Mhm.
being emotionally equipped to
There's
be able to handle that.
It's
Like,
that part.
I will tell you right now, and he may see this. My husband would not be emotionally equipped. God forbid something happened to me, because it would be too much of a stressor for him. So it is vital that I have things in place that could guide him along,
Yes.
so that he doesn't have to be in the position to make those decisions.
Right.
And I think it's almost, and I'm going to say it, I think it's one of the most selfish things for us, for those of us who can, to not have those things in place.
We need to put things in place because we never know when
You
something's
never know.
gonna happen.
If you have children, if you have a spouse, if you have people who are dependent on you,
Yes.
just put the things in place so that they don't have to think, because there's already so many other emotions
Right.
involved.
It takes away that pressure when you are, first of all, having a conversation. What is it that you would want? Who
Right.
is that person? Some
Right.
people can't handle the pressure. Much like you, my husband is the opposite. He's going to get a lot of pressure because I raised my younger sisters after my mother died.
Oh.
So they were preteens. So I am this beloved older sister of 6 children that my mom had. And if something happens with me, they are going to be like on him, like
Swarming.
piranha. They're going, Bernard, what you doing? What you doing? What? Especially that baby sister. But he is very resolute in what he feels like. If he's going to believe God first of all, because he's going to want his wife to stay alive for a while. But he will make the decision. He won't let them pressure him. But there are other people who may cave under the pressure because well-meaning people always have something to say.
Right.
The peanut gallery is going to always have something to say unless you already know what that person told you. And then you can say what you want. Do you want CPR? Do you want to leave it to the discretion of your agent to make the decision in the moment? Or do you want them to do what you've asked them to do?
Right.
So there's that piece. Now, as it relates to the other documents that happen when people are seriously ill, the post form, which is physician orders for scope of treatment, is a tool that can be used by clinicians to begin conversations with families if their prognosis is a year or less.
Right.
And so there are 3 sections. Section A talks about, do you want CPR or no CPR? If you say that you want CPR, Section B then begins to talk about, do you want comfort measures? Do you want limited trial period for something? What does that look like? And the patient has to sign it, and the physician. It is a medical order.
Right.
So EMS, if the patient has that form and something happens, then EMS will respond to what is in those sections.
Right.
Most hospices are going to use the EMS do not resuscitate form. Why we have 2 forms? We have 2 forms legislatively approved. I would love to see that we could consolidate those. So
let's talk about that. I love a good legislative moment. We'll talk about that later.
But the EMS DNR form is for terminally ill patients who meet the criteria of 6 months or less. It is also signed by the patient, and it is a medical order signed by the physician. So that particular form, most hospices are going to have that somewhere above the patient's bed, because there's always someone who forgets the instructions to call hospice first.
Right.
So, well-meaning Aunt Sally saw so-and-so took their last breath, they already calling 911. Now 911 shows up, they can respond to that medical order by not resuscitating the person. They cannot respond to an advance directive.
Right.
That advance directive shares their rights, but it is not an actionable medical
because that could be revoked by the present parties,
It's
right?
not a medical order.
Gotta have the order. We know that. That's how we operate.
Well, what about? Well, this is where it starts getting the fun drama, and I know Nita Rutherford talks about this all the time about like update your paperwork and
Mhm.
update the importance of what you have if your life changes.
Right.
Mhm.
Have I seen 15-year estranged spouses come to bedside
And they show up.
and they go, everyone out,
And legally,
and legally,
they can do that.
And that's why
They
you
can
need
do
to
that.
have your affairs in order.
exactly.
If y'all get nothing else out of this time with Sweet Tea and Stethoscopes today, get your affairs in order.
Get your house
In order. Oh,
do it today.
see,
Oh,
that's a
we done
good.
went
That's
to
a,
church.
we about to go to church.
Come on, give me one, Ryan.
We about to go to church. But isn't that true? Look, even the church telling you need to get your house in order.
But the scripture says that God told Hezekiah he was about to die, get your house in order.
Listen, listen. So
I
y'all
can tell y'all that I was also a preacher.
no.
Oh,
I was gonna say, so we got a little word today, y'all got a little song today, we got a little tea today, and we got some education
Yes,
today.
I am an ordained minister. Yes.
I love it.
Goodness. On top of it all.
Listen, I love it. I love it. You talked about bereavement. We talked about the death, death and dying. We talked about all these stages. We talked about all this stuff.
Mm-hmm.
And when you have all of this, you got the resources, you know what to do, but you don't have a place. Let's talk a little bit about some resources. Like who can I call? Who you gonna run to?
Mhm.
Who can we reach out to? Who can a family reach out to? Or what, even if it's just online, what resources are available?
Well, in terms of resources for palliative care, there is a site that says it's called palliativecare.org, getpalliativecare.org.
Getpalliativecare.org.
Getpalliativecare.org. And on that particular website, it will show you everywhere where someone has a palliative care program. It will show you what type it is, whether it's a visiting home program, whether it's an inpatient palliative care program. It will give you all of that information. Now, as it relates to getting the services, you can self-refer yourself to your doctor if you've got someone in your family like a TK that knows that you need that, or a Marisette. There are nurses out there. You can call and say, hey, I would love to have an evaluation for my loved one for palliative care.
Right.
And we want people to get palliative care so much earlier,
Mhm.
where they get that support at home.
Yeah.
They're able to understand to take care of those distressing medical symptoms. So we can enhance their quality of life while they're still getting treatment.
Right.
And so the hospice physician, you don't have to have an order to have an education.
Right.
But in order to be admitted to hospice, there does have to be 2 physicians who certify that it is the right time, that the prognosis is 6 months or less.
Right.
And so 2 physicians have to have that certification. And so we also have the Association for Home Care and Hospice that has a website, and they on their website also it allows you to sort of go by county to see which hospices are there.
Mhm.
The last great resource that's out there is Medicare Compare. So Medicare Compare will allow you to go out there, just like they have Nursing Home Compare, Hospital Compare, Medicare Hospice Compare. You go into it's MedicareHospiceCompare.org. You can just do a doodle. And when you get out there, it will allow you to put your zip code. When you put your zip code, it will list all of the hospices that cover either your county or that particular zip code.
Mhm.
It will also allow you to see what are their ratings.
Love that.
So it is a
Fantastic.
quality assessment tool. So often when I talk with consumers, they'll ask me, well, what should I really think we need hospice. What should I do? I say, first of all, you do not have to take the first hospice that your doctor refers you to.
Right.
You have the right, and you should interview 2 or 3 programs. You want to know a few things about those programs. How much time will it take for their staff to get to you for a routine visit?
Right.
What is the time frame it takes for them to respond if they needed to make a visit after hours? Do they have volunteers? Because every hospice is supposed to have volunteers.
Right.
Do they have volunteers in the area where you live? And so you want to know about what their makeup is. Are they accredited or not? You know, hospices don't have to be accredited, but those who are have gone the extra
Higher
mile.
standard, right?
It's that quality standard. And then you can even, like I say, go online and look at what their ratings are from patients related. This is the quality assessment piece that Medicare does. How are they with managing pain? How are they in terms of how they their response time? You know, there are certain questions that the hospices are having to answer, and those things are aggregated, and you can compare. You can say, okay, I want to look at 3 hospices in this particular zip code, and they'll put them side by side, and the one that you're looking at, you know, take the 3 that you want to look at, they'll give you a comparison about what they look like on paper in terms of comparison. Now, does that tell the whole story? It doesn't. But also, I think, too, word of mouth. People, when they get good care, they tell everybody about it.
100%.
But if they get bad care, they also
Tell
tell people
everybody.
about it. I'm a hospice advocate, and I want to say that every hospice should be doing it right. But sometimes there are things that happen. In our state, we have about 84 licensed hospice providers.
Wow.
And so we have some counties that are covered with 30 providers covering one county because we don't have a CON process to sort of vet people who want to open a hospice. So because of that, for home care hospice, there is no CON requirement like it is for home health. Now, if you want to open up a hospice inpatient unit, there is a CON process for that. And we have about probably 15 hospice houses that are in South Carolina. So I think, there's that piece of that as well. That's why we have a lot of programs, much like how we have churches on every corner. We have lots of hospices, all sizes, shapes, all of that in terms of how many people, they serve, that kind of stuff. And I would never say that a small provider who has a small number of patients is not as excellent as someone who's larger. It's not based on that. It's really based on the staff that they've assembled, the culture of that organization to provide the best care possible. Some people don't want to be huge. They've got a market that they're in, and so they're recruiting those particular patients. So those are really where your top areas are in terms of getting resources. Now, physicians, this is something that you'll see a lot as it relates to hospice, is many primary care physicians are connected with a hospice because they may be a medical director of a particular program. And so, that does happen. And patients will sometimes say to me, well, the doctor wouldn't let me go to this organization because he said he's not the medical director for that particular hospice. And I said, patient choice is still what we stand on. And so, if you desire a different hospice, I'm not saying that your physician is wrong, but if you desire to be served by a different hospice because your family was treated by hospice A, for all of the people who have died, and sometimes that happens,
Right.
then you have the right to choose the hospice you want. And the medical director can serve as your primary attending while you're on hospice. We don't force people to do that, but we do want to encourage people to choose, that, this isn't a dictatorship about which program that you're going to use.
Right.
The same thing happens when people are in nursing homes. You can receive hospice while you're in the nursing home.
I've seen many a patient in a nursing home.
Nursing homes are quite the same. They have particular hospices that they are working with. And so sometimes they don't want to have the patient have a provider that they don't have a contract with, which is understandable. But what I will say to them, I always have a reason why you can still choose. Ask them if they will give you a one-time, one-patient agreement. Because if you've been serving this person in their home for all these months, and now they're going to be transitioning to a nursing home, the continuity of care is important. The trust with the patient, with the staff that they've been working with. So they could, if they're willing to, do a one-time, one patient contract with that particular organization. There's the power dynamic that our seniors have sometimes because, first of all, the doctor has this aura, and God forbid we remove that. I understand what that aura is, but for a lot of our elderly, they've seen the same doctor for years.
Right.
And so they don't want to move away from that trusted relationship, and you can understand it at this time. So many of them will go ahead and choose the provider that that the physician has recommended. But when you get into the nursing home, that's a whole nother different
Right.
piece
Right.
right there. And so they're going to go into an environment where they don't know anybody. They
Right.
don't have a connection with them. They don't know them. And so now, the person that they know is that hospice that's been working with them in the home. And sometimes people aren't able to keep their loved ones at home, and it's okay
Right. That's
because
okay too.
there are much better nursing homes now than there were 30 years ago.
Right. Right.
So,
And the choice is there.
the choice is there. They're highly regulated, just like hospices are highly
Right.
regulated, and home health is highly regulated.
Right.
So, everyone starts out with being licensed by the state, and if they're going to get Medicare dollars, they have to go through a Medicare certification survey.
Right.
And they have to get surveyed every 3 years at least. So we know that that's the floor. But what people do to sort of excel themselves is, okay, how many of these programs in South Carolina have gone the accreditation route?
Right.
If they've not been accredited, how many of them, what are their scores look like on Medicare Compare, on
Right.
Medicare Hospice Compare? So,
I think that's good. And I know we're getting close to the end of our time, but I want to kind of let us close out. And Ryan, I'll let you take the lead on this.
I mean,
Thoughts on today?
as a new nurse who's only seen such a very small fragment of what hospice care and death and dying could be, not only just for the patients and the families, like, thank you so much for being such a wealth of knowledge and very passionate and uh, bringing both personal and professional experiences to this conversation, because I don't think a lot of nurses get to see that, or they either are perpetuating some of the same community stereotypes that we have around death and dying,
Right.
or um, don't know how to facilitate those conversations, or even have the knowledge to just push families or guide families in the directions that they may or may not need at any step of that process, whether it's, hey, this might be the time to get that advance directive, or hey, maybe this is the time to seek out additional help for family transitions, or helping them connect to their communities, their religious organizations, their cultural roots. And if they are planning on transitioning in a different place than where they are at now, you know, having the idea of what the community resources may be for them.
yeah.
So,
Well, I want to just give a shout out to interdisciplinary teams as my closing remark because none of this is done in isolation. We need a team.
Right.
And what I so love about what we do in the hospice arena is having the social worker. I don't have to be everything to every patient because I have a social work. I just thought of June Scruggs just then. I have also a chaplain.
Right.
I have the CNAs that are going into the home. And how many times did I go see a patient and the patients told me that the nurse had already been there, but
Right.
it was
It
the
was the
aide
CNA.
Mhm.
because they do important work.
Oh
Right.
my goodness.
100%.
They are in intimate spaces with
Oh my
them.
goodness.
And so the medical director, I love the fact of the collaboration with the medical director and the hospice team. Um, Everyone is able to share what they're seeing about the patient, and the medical director provides that guidance in terms of the medical interventions, but also is that ear to hear because the team actually are the ones that are letting him know what's happening in the home. So I absolutely appreciate that. But I also appreciate the fact that there's someone at the office answering the phone is so special. And those administrators who make the investment to educate, who see that that's valuable, for the team. I appreciate. I was one of those administrators. I moved up the line and was a nurse and a patient care coordinator and then an administrator, and so I get it. And if you don't invest in your team is the representation of who you are out in the field.
Yeah.
And so
100%.
shout out to those administrators who are doing a great job to create a culture that works, for their team. I'll stop there.
No. My next question for you is, how can we support you? Or what plugs do you have for us to support your ministry, your practice, the programs you work with? How can we connect with you?
If there are hospice nurses out there, I'll give a plug. I'm doing a hospice boot camp
Okay.
on November the 20th. And so they can go to my website, lifespringsconsulting.com. And just click the link that says register for the boot camp. And it's going to be, there's some new regulations that have come out. It's going to be a face-to-face. I know a lot of people do virtual, but when we did this, the nurses said to us, we appreciate that you did this in person, because had you done it online, we would have not had our cameras on and we would have been multitasking.
Right.
And so there's something that happens when we come together as nurses in community and we interact, face to face. So
And that's just something that'll never be taken away with the rise of AI and the continuing evolution of technology, that interpersonal thing. No matter how many discussion posts you have to do in your next program, like, those interpersonal relationships just can't be
It can't
replicated.
be right. Not in any way.
yeah, well, thank you guys so much for having me today. It's been so much fun. This podcast, I think you guys could chop it up and put it out there during National Hospice Month,
Yeah.
next month, and be able to put it on your social media platforms, because so many people, and invite them to share their stories. Because I think that's the other thing, is that we can take people's stories and hear their questions, and we can respond to their questions with the right information.
Well, thank you for coming. Thank you for answering my call. We've talked a lot about all the things, right? But death is not scary when you are armed with the right information. It is a part of life. It is a part of the natural progression of life. We will all be born, and at some point in time we will all die. And we don't want to be afraid of having those conversations. And I think having conversations like this one that we've had today can help quell some of those fears for some folks. I would just say, if you are a person who might be afraid, who may be dealing with something like this, who may be unsure, or just trying to prepare yourself, reach out. Reach out. Let us support you. I'll do the plug for the Nurses Association. It's not something that we do day in and day out, but one of the things that our job is to advocate, and the way that we advocate is to provide resources and connect you. So www.scnurses.org. Go on, fill out. I got a question. We'll answer it. Send us an email, info@scnurses.org. If I don't have the answer, we'll find an answer. We'll
have the
find you.
network.
We have the network. Lastly, and most importantly, thank you to the viewers and the listeners of Sweet Tea and Stethoscopes.
Yeah.
Thank you for taking the time to learn a little bit about death and dying today, and for being willing to have a conversation that's not the most comfortable. I think that's what we do here. We spill the tea in every way we possibly can, good, bad, or indifferent. And today it was a little heavy, right? We found some levity along the way, but it was needful and necessary. And I think that's what's most important. So yeah, I'm good. I'm happy.
I'm Ryan.
I'm Marisette.
And I'm TK.
And
we just spilled the tea.
I love it.